Good morning, everybody, and welcome to the Head and Neck block. Just wanted to thank the CAGLA, committee for giving us the opportunity to have this section again, and also the opportunity to moderate it. I'm excited to introduce you to the panel of speakers today who are exceptional in what they do. And I also have the privilege of, working with them on a day-to-day basis. So we're going to start off the session with Dr. Mualla, who is an assistant professor in the Department of ENT here at LSU in New Orleans, with her focus being head and neck cancer surgery, robotic surgery, and microvascular reconstruction. And she practices mainly at Our Lady of the Lake Regional Medical Center in Baton Rouge. After that, Dr. Kansara is going to be talking to us. He's also an assistant professor with the Department of ENT at LSU. His focus again being head and neck cancer ablative surgery, robotic surgery, and microvascular reconstruction. His practice primarily, again, is at Our Lady of the Lake Regional Medical Center. And then Dr. Brown is going to be talking to us about radiation oncology and certain nuances of how this affects underserved population. And her practice is mainly at LCMC Health. We have the pleasure of working with her at University Medical Center, but she also has a clinic and practice at West Jefferson Medical Center. And finally, Dr. Melder, Katie Melder, who is recent new faculty to our department. I think, Katie, you've been around for a year now? A year and a half, right. And her specialty is skull base surgery. She treats tumors, both benign and malignant tumors of the skull base. Is an assistant professor with the Department of Otolaryngology at LSU. Her practice is mainly at University Medical Center here in New Orleans and at West Jefferson Medical Center. So, I'm really looking forward to these talks myself, and just for some housekeeping things, we'll try to leave the Q&As to the end so that we can get through the content, and I want to make sure that everybody has enough time to speak. Also, I understand from Avery that you have to come close to the mic and speak, so because there are some problems with the audio. But other than that, let's get this session started. Dr. Mualla, please.
So like Dr. Welvacar was saying, I'm Rula Mualla. I work primarily in Baton Rouge. I'm one of the head and neck surgeons there. And so what I'm going to be talking about is the challenges in early detection of head and neck cancer. I have no disclosures. So as many of you probably know, head and neck cancer refers to cancers of the oral cavity, oropharynx, larynx, hypopharynx, nasopharynx, salivary gland, and sinuses. And it accounts for approximately 4% of cancers in the US. Risk factors include smoking and drinking, typically presents in the 6th or 7th decade of life, though recently we're seeing it a lot in more healthy non-smoker patients, especially in the oropharynx due to HPV. Approximately 2/3 of patients diagnosed with head and neck cancer present with advanced disease, so stage 3 or 4 disease. And this percentage, unfortunately, has not changed significantly since the 90s, despite advances in imaging and diagnostic tools. So this is a paper that showed that 61% of patients were found to present with advanced disease, stage 3 and 4 of head and neck cancer, had about several thousand patients. It was a review article. And the greatest percentage of those were in the oropharynx and hypopharynx. As you might expect, as stage advances, our survival outcomes worsen. So this is more recent data from the National Cancer Institute looking at 5-year survival rates by subsite. And as you can see, as stage progresses, our survival rates fall significantly. And this is for larynx and hypopharynx. So, going from an 85% to sometimes less than 50% for a lot of these subsites. So why do head and neck cancer patients present late stage? So there are a variety of factors that we'll talk about: socioeconomic status, insurance status, geographic region, symptomatology, and delay in diagnosis. So I'd subdivide them in what prevents them from coming to the doctor, and once they get there, what prevents them from getting diagnosed. So this is a systematic review from 2024 looking at inequities associated with advanced stage at presentation, head and neck cancer. So 50 articles focusing on US populations that found that male sex, lack of insurance, living in rural areas, and low socioeconomic status were identified as risk factors for advanced stage at presentation. This is another article, again, also focusing in the US across multi-centers with 500 participants that again showed that advanced stage associated with an insurance status, tumor location, and dental disease. Now, this dental disease is, I think, probably a proxy for the type of patient who is not being seen by either a primary care physician or a dentist regularly, but it has been found across multiple studies. This is actually an international study, and I like to include this because obviously insurance is a huge issue in the United States, but there are lots of countries that have nationalized health insurance, and so kind of trying to take that out of the equation, what do we see? So this is looked at eligible studies between 97, 2020, again representing the USA, but also France, Denmark, Taiwan, Japan, Spain, Italy, and a few others. And these are the factors that they looked at: tumor stage, sex, insurance type, race. So they found that oropharyngeal carcinoma was associated with the longest delay of diagnosis across multiple studies, and that the risk of delay for African American and Hispanic populations was significantly more compared to Caucasian populations, and that in the USA studies specifically, insurance by Medicaid and treatment at an academic facility were associated with increased delay. This treatment academic facility I thought was really interesting. I think this is probably based on referral patterns. In fact, there's a study I'm going to highlight later on that shows the exact opposite of this, but something I thought was interesting in this article. And then finally, this is just is my microphone still working? Can you hear me? Oh, there we go. This is something that just showed, was looking at intersectionality between race, ethnicity, and residential level socioeconomic status. So they looked at tens of thousands of patients with head and neck cancer, stratified them by socioeconomic status, so low, middle, and high, and then saw, what is changing in outcomes specifically, so 5-year overall disease survival. And they found that Black patients, no matter the socioeconomic status strata, had significantly worse outcomes than their peers. So that is the kind of factors affecting patients' access to care. The other part of that is the symptomatology and anatomy of head and neck cancer. So patients who present with head and neck cancer just have very vague symptoms: mouth pain, sore throat, some hoarseness, difficulty swallowing, persistent neck mass or ear pain. And they're in areas that we cannot clearly see. So we can look in the mouth for the most part, but nasal cavity, oropharynx, larynx, hypopharynx, those places are only accessible basically via scope, which obviously not everyone is capable of doing. So it becomes a lot harder to identify these patients earlier. The other part of it is the patient factors. So I have found that our patients tend to have poor medical literacy, and they tend to ignore their symptoms for longer periods of time. And a lot of that is an association with smoking. It has been found kind of across studies that there is a correlation between history of smoking and delay in care. I think that's multifactorial, but I also think that a lot of patients, and I know this anecdotally, a lot of patients who are smokers have some degree of hoarseness, pain at baseline, and so if there is a change in that, they tend to brush it off. The other part of it is that patients, when surveyed, who smoke especially, have noted that they've blamed either lack of awareness of symptoms or not knowing that smoking and alcohol causes head and neck cancer. Now, that seems crazy to probably most physicians and other providers, we all know that smoking is associated with increased rates of cancer, especially head and neck cancer. But I can tell you anecdotally, I hear this all of the time. I had no idea that smoking was going to increase my rates of cancer. So it does happen. So that's the part of what prevents people from coming to us. The second part of that is once they get to us, why are we not seeing them promptly? So this is looking at causes for delay before a patient presents to a head and neck physician, radiation oncologist, something of that variety. So they found that persistent neck mass and difficulty breathing were more likely to prompt an early referral, whereas hoarseness, like I mentioned before, was correlated with longer patient delay. Some of that is because providers themselves, if they hear a hoarse patient who smokes, they're probably not going to have a high suspicion for cancer. In fact, I just saw a patient actually whose very large laryngeal cancer that was actually obstructing their breathing was found incidentally because they were being worked up for a lung nodule and found this mass on imaging. I had to do an awake trach that same day. The other part of this is, so we are seeing an average between 48 days to 6 months from first presentation to the primary care physician to the time that they see a subspecialist like myself. And that delay increases in patients who present with early stage disease. Like I said, a lot of that is low suspicion on the provider who was first seeing them for neck mass, hoarseness. I can't tell you how many times I've seen patients who've presented with a mouth sore or neck mass and have just been given several courses of antibiotics, before they've finally been referred. So this is another example I wanted to show that I thought was interesting because, again, Canada has nationalized healthcare, and so we've kind of taken that out of the equation. Are we still seeing the same rates of that delay when we're maybe improving access to care? So this included new patients presenting to the head and neck clinic between 2017 and 2018. About 400 patients were included. So once they presented to the head and neck center, they filled out a survey, and then their previous medical history was collected and appointment data. So they found a total delay in diagnosis from first symptom onset to a presentation at head and neck clinic was about 15 months. And the average time of symptom onset was to presentation to the first provider, which was typically a primary care physician, was only about 4 months. So most of that delay was from provider presentation to referral to a head and neck surgeon. And they didn't find that tumor site, socioeconomic status, or smoking history correlated with the delay. Now, I will say there have been other studies, like out of Finland, who also has nationalized healthcare, that did find that socioeconomic status changed delay of diagnosis. So that might be not entirely accurate. And like I said, the greatest delay was provider cause, almost 11 months. And 50% of those patients had to see 3 different primary care providers before presenting to a subspecialty clinic. And so finally, this is another study from the U.S. from 2015 that looking at factors associated with delays in head and neck cancer treatment, which is a case control study. So they took 50 patients that had what they call prompt care, so within 60 days, and then 50 patients who didn't, compared them, saw what was causing this effect. And they found that there was a significant association between referral to a non-head and neck cancer center and a head and neck multi-disciplinary team member and treatment delay. So we are seeing in general that if these patients are seeing head and neck subspecialists early, that they're getting more prompt care, which makes sense. So I am now looking at this within Louisiana. So I'm working with the Louisiana Tumor Board Registry, looking at, what is causing our patients to present with advanced stage. So we're looking at cases between 2017 and 2021, again, representing oral cavity, hypopharynx, larynx, and oropharynx. So we did a logistic regression model that included age, race, gender, insurance status, poverty level, and geographic location. So that was a binary urban versus rural for patients with either stage 3 or 4 head and neck cancer. And we did find a correlation. So patients that of Black race and Medicaid insurance status were associated with more advanced stage at presentation. And then even controlling for race and poverty, Medicaid is an independent predictor of advanced presentation. So that begs the question, what do we do with this information? So some of it is still, I think, being figured out, and that's having to do with screening tools. Like I said, a lot of this stuff is hard for a primary care physician to see, and until we're training all our primary care physicians in endoscopy, which seems unlikely, how are we possibly catching these early on? So there is some good or some new, at least advanced liquid biopsy tools for HPV that's now being looked at. So if there is a way that we can potentially pick these up on labs early on, that would be a great way of potentially us capturing these patients. I do think we need more physician education, especially at the primary care level. A lot of now that we're seeing so many new oropharynx cancer cases, especially in younger people, a lot of these patients are presenting with only a neck mass and no other symptoms. And they're being treated with an IND, an incision and drainage, or antibiotics instead of referral to a head and neck cancer surgeon. So training these patients on what to look for, and if it's a chronic neck mass, that needs to be seen by a head and neck surgeon sooner rather than later. And then I'm specifically looking at interventions within Medicaid. What exactly is causing this delay, and how do we fix it? Because we are seeing across multiple studies now that Medicaid insurance status alone is a predictor of delayed treatment. And then lastly, medical literacy. So our patient population does have low medical literacy. They often don't know what to look for, or brushing their symptoms aside. I don't know if you guys remember this commercial from when we were younger. It was a lady who had a laryngectomy. It was an anti-smoking ad. I remember this vividly to this day, and I've actually had patients that I've given laryngectomy education who specifically asked me about this lady. Am I going to sound like this lady after? So these things do work, and I don't know if we need to put laryngectomy patients, on all of our ads, but I do think, having these commercials and having an awareness of what, laryngeal cancer and other head and neck cancers look like is important. These are my references. Thank you.